I have brought to you landmark guided peripheral nerve blocks. So let's start. These are some of my credentials. Now, the highlights of my session will be, first of all, I will be describing the ergonomics. Then the last, that is local anesthetic, systemic toxicity, and risk management. And in upper limb nerve blocks, I will describe axillary brachial plexus block approach. And in lower limb nerve blocks, I will describe femoral nerve block. And the remaining blocks will be described and elaborated by Dr. Maimouna Sheikh in her second presentation. Our main topic, landmark guided nerve blocks. Landmark guided refers to the technique based on the palpable anatomical structures, our landmarks. Now, there are misconceptions about it. People used to call it like it's blind. Let me tell you, it's not blind. Actually, it's a sophisticated 3D mode of thinking. It involves palpation, anatomical knowledge, spatial reasoning, that is mental projection of external landmarks, and the tactile feedback, that is interpreting the feel of the needle as it passes through different tissues, like you can feel the facial clicks, the pops, and all this, and the loss of resistance. Yes, of course, right? Now, the peripheral nerve blocks for the upper limb, as I've already mentioned, I will briefly describe the axillary approach for the brachial plexus block. And in the lower limb, I will describe the femoral nerve, and the other blocks and the other approaches will be discussed by Dr. Memo. So about peripheral nerve block, first of all, there is brachial plexus. Who can forget the brachial plexus? The nerve supply of almost all of the upper limb, it just comes from the branches of the brachial plexus. That is made up of C5, C6, C7, C8, and T1 nerve roots. Now, if you want to block the roots, you can block the roots over here. Over here by using interscalene brachial plexus approach. To block the trunks and deviance, you can use supraclavicular brachial plexus approach. And for cords, if you want to block the cords over here in this part, so you can go for infraclavicular brachial plexus approach. Now, as my topic is axillary brachial plexus approach over here, so our main focus is this. So over here, you can block the terminal branches of the brachial plexus that are mainly, so median nerve, radial nerve, ulnar nerve, and the musculocutaneous nerve, right? So the four main terminal branches, musculocutaneous, median, radial, ulnar nerve, can be blocked by using axillary brachial plexus approach over here in this part. So, yes. Now about the nerve supply of the upper limb. So this is the nerve supply of the upper limb. As you can see, the osteotomes, the myotomes, and the dermatomes here. My topic is related to axillary blocks. So let's focus over here, just below the elbow, the forearm part. Now, as you can appreciate that most of the forearm, the osteotomes and myotomes, they are supplied by radial nerve, this purple one here, then the median nerve, the green part, right? And the red one, the ulnar nerve, this. So, and some part is also supplied by the musculocutaneous nerve over here and over here. But this part, the green part, as you can see, this is the medial antebrachial cutaneous nerve. That is the part, that is a branch of the medial valve. So now the main supply comes from the radial nerve, median nerve, musculocutaneous nerve, and ulnar nerve, but just a little part of the skin, that is the medial part of the skin, is supplied by the medial antebrachial cutaneous nerve. Okay, now about the forearm surgery. If you're like willing for to provide regional anesthesia for a forearm surgery, what you have to do? You need to block radial nerve, musculocutaneous nerve, and sometimes medial cutaneous nerve or the forearm. Plus minus, I have mentioned plus minus because it depends upon the site of the incident. If the medial side is not involved, then there is no need to block medial cutaneous nerve. Just forget it. Then you just have to block musculocutaneous nerve, radial nerve, ulnar nerve, and medial nerve, and forearm surgery can be performed under axillary block. Same goes for hand surgery. As you can see, dermatomes, myotomes, osteotomes, all are covered by these three nerves. The ulnar nerve, radial nerve, and medial nerve, they are covering the hand. So hand surgery can be performed under axillary block. Okay, so about the axillary approach. Now, this is the axillary artery, this red one, as you can see here. My cursor, my pen is moving, as you can see. So the axillary artery, this is a continuation of the subclavian artery, and three nerves accompany it and shares the same sheath of the axillary artery. Now, as you can appreciate here, on over here, the three nerves I have mentioned is the radial nerve. One is the radial nerve, second is the medial nerve, third is the ulnar nerve. These three nerves, they share the same sheath as of the axillary artery. But the musculocutaneous nerve, it comes separately, it travels down separately in the coracobrachialis muscle fascia. So let's have a look on the relation of the axillary artery with the nerves. This is a very self-explanatory picture. This is axillary artery. This one is the median nerve that is made up of two branches from the lateral and medial cord. Then ulnar nerve, that is the terminal branch of the medial cord. Over here is the radial nerve, as you can see. On the posterior side, on the anterior side is the median nerve, and on the medial side is the ulnar nerve. Now, where is the musculocutaneous nerve? So let's find where is the musculocutaneous nerve. So now look here carefully that this one is a musculocutaneous nerve. As I have already mentioned, it gets separated from the cords very early in its course in the axilla, and it pierces the coracobrachialis muscle fascia, and it travels separately. So this is very clear from this picture over here. This is coracobrachialis, its fascia, and this is the musculocutaneous nerve. It's piercing the fascia and it gets separated. Now these three nerves are just accompanying the axillary artery, and while this independent nerves, it's going separately. So sometimes you have to block this nerve separately, and these three nerves can be blocked single-handedly alongside of the axillary artery. Now, indications, very important. As I have already mentioned, the forearm surgery and the hand surgery can be performed under axillary approach. So let's see, surgical procedures on the forearm, wrist, and hand. Fracture repair, carpal tunnel release, tendon repairs can be performed. It can be used for post-operative pain management for these surgeries, and of course, the management of acute pain conditions affecting the forearm and the hand. Important considerations to be remembered: nerve proximity. As I have already mentioned this, the medial, ulnar, and radial nerves are typically found in close proximity to the axillary artery, and the musculocutaneous nerve is often separated and it lying within the coracobrachialis muscle. Complications, potential complications include vascular puncture, formation of hematoma, nerve injury because of the needle injury, and lastly is that is a local anesthetic systemic toxicity. This is the only tray we need. The only things we require are the drug-filled syringes, scale sometimes we don't need this, marker, drapes, iodine, antiseptic solution, gloves, and most importantly, intralipid. Do not forget it. Now, thankfully, it is available in Pakistan. So be safe while performing regional anesthesia. Now, coming to our main thing, the landmark technique of axillary nerve block, axillary brachial plexus approach. Okay, the surface anatomy. Now, the patient is, you can see the patient is lying supine with abducted arm at the 90 degrees. Now, the main landmark in the axillary approach is the axillary artery. It is the primary landmark. So you need to palpate the axillary artery in the axilla as much higher as much possible in the armpit. The landmark will be pectoralis major. Let me show you. Let me draw it here. This is pectoralis major. This is biceps brachii, and this is axillary line. This is axillary fold. So just on the outer border, the lateral border of the pectoralis major, the outer border of the pectoralis major, the lateral edge of pectoralis major, you can palpate the axillary artery over here as proximally as possible. First of all, just palpate the artery, then mark it, that outline the landmarks. Now the second part, you might be wondering that why the marker was in the tray. Marker was in the tray, the pointer was in the tray because just to outline and mark all the landmarks on the surface to make it easier and for the future references and to guiding your needle. Now let me explain this. Now this is the border of the pectoralis major. This is, of course, this is artery. This one over here is biceps brachii. This is biceps brachii. This one over here is coracobrachialis. This one over here is triceps. Now we have to put our fingers over here and then the show will begin. Now there are two approaches, transarterial and my most favorite one, and I just personally use the second one, that is perivascular needle double injection technique. And I will tell you how we do this. Transarterial injection approach. First of all, after making the position, prepare the skin, place second and third finger on either side of the artery to anchor it. Advance the needle at a 90 degrees angle to the skin to puncture the artery, and you will see the pulsatile bright red flow, bright red blood. The needle will advance further until the blood stops. It signals that the needle tip is now posterior to the artery. Half of the volume of local anesthetic is injected after aspiration and in fractionated doses. The needle tip is withdrawn. Keep aspirating until the blood stops. Now that shows that tip is now outside of the artery. Now the remaining half of the local anesthetic is injected again in fractionated doses. Now here is a video demonstration of it. These fingers over here are used to palpate, to anchor it. The needle is advanced, the blood is flashing out. As soon as the blood stops, just forward advance your needle further and then inject the drug. See, the blood is flashing out. Advance the needle until the blood stops and then you can give your drug. This is another one. If you don't want to use the syringe, the whole syringe, just use the needle. Now, to insert the needle at 90-degree angle to the skin, blood flashes out. As soon as the blood flashes out, advance the needle until the blood stops and then just give the blood and then give the drug. It is very simple, but usually I fear the transarterial approach. I personally don't like it. I use the other technique. Let me show you my technique that I have learned from my respected teacher, my supervisor, that Professor Dr. Sairah.Live. He's also here. So I have learned that technique from him. Now, my favorite technique is just after marking the artery, after outlining the artery on the skin, we will use these two positions, above and below the artery. First of all, the needle will be inserted above the artery, that is position 1, as you can see here. Okay. And then look for the maximum movement of the needle with every pulsation. Now, when you will insert the needle over here, just in close proximity to the axillary artery, you will see the movement of the needle. Okay, on negative aspiration, inject the drug. Now withdraw and reinsert the needle on the second point, over here, the second position. Watch for the maximum movement of the needle with every pulsation. On negative aspiration, inject the drug. Now I will show you what is meaning of the movement. Now look here. I will play it for you again. Can you see? Can you appreciate? I hope you can appreciate its movement with every pulse. Okay, yes, that's good. Let me play it again. Now here was the artery. Now, what does that mean? What does the movement of the needle means? It means more the movement, it means the needle lies more close to the artery. So that means it lies more closer to the artery. So now that is your target place. You can inject the drug after careful aspiration. You can give the drug. So that is very simple, easiest method of performing axillary block. That is, I think I just call it, I just say it is safest because you don't have to puncture the artery. You don't have to go through and through the artery. This part. After injecting, do not forget to lift and raise the arm for 5 to 7 minutes for more proximal spread of the local anesthetic. This is the second technique. After injecting the drug, you are going to block 3 nerves. But by doing this, lifting the arm, what you're doing, let me show you. The drug will spread more proximal, and thus it will block musculocutaneous nerve. So it will just solve our problem. The issue that was, we were worried about how we're going to block the musculocutaneous nerve. So just by lifting the arm for 5-7 minutes, it will make it easier for local anesthetic to reach the musculocutaneous nerve, and so it will block the musculocutaneous nerve will also get blocked. So that's easy. And let's say if not, what if not? You may ask, ma'am, if still a musculocutaneous nerve fails to be blocked, so what to do? Okay, let me show you. So what to do then? Okay, what you have to do then is that just while you were performing the transarterial approach or the perivascular approach that I have told you, that first go into the position 1, then go into the position 2, and after injecting the drug here, withdraw your needle and redirect it at 45 degrees, a steeper angle, into the cricobrachialis. Inject the local anesthetic here. 5 ml is enough to block the musculocutaneous nerve. That is the musculocutaneous, right? Someone is asking that what is the angle? Okay, someone is asking what is the angle. So the 90 degrees angle. Go straight at 90 degrees angle, perpendicular to the skin, for the block of the 3 nerves, radial, median, and ulnar. But for musculocutaneous, just withdraw the needle and make a steeper angle, reach up to here. You may feel a pop when you will be inside the fascia over here, and just inject. After careful aspiration, inject the drug. Right? Okay. Let me stop it for. Can it be stopped? Oh no. Okay, I have recorded this video just to show you that what lies underneath the surface landmarks. Now you can easily correlate the surface landmarks and with the internal anatomy. So it is just to show you guys that you are at the right spot. See, I have okay. Okay, I have marked the artery here, as you can see. And after putting the probe here, this is, this one, this is the black line, that was the artery. When I have put the probe over here. So this is the artery. My probe is here. Here is my probe. Just to make sure that, yes, I am doing right. So this is a musculocutaneous nerve in the separate fascia. And these small, you can see these small lines over here. Some, and one where I just saw one here. Okay, so these are the radial, medial, and ulnar nerves over here. And some other branches coming along. So these are in the same fascia of the axillary artery, while musculocutaneous nerve is here. So the answer of the question is, you just go straight down for the transarterial approach. And the second approach, perivascular approach, that I use is above, like 10 to 15 mLs here, 10 to 15 mLs here, and the few mLs that are left, just withdraw your needle, come like at a steeper angle. If you here in the fascia, you may feel give way. Just after careful aspiration, inject your drug. So that's all about the axillary approach. Now,